Thank you. Firstly, I thank SM organizing team for giving me opportunity to talk on this particular topic. Simulation to survival, building a high performance emergency medicine teams. Here I will be sharing my experience of 1.5 decades over the simulation, which we transform into excellence in research station and which resulted ultimately in better outcomes. No conflict of interest. How simulation transforms the protocols into performance and performance into patient survival. This is the theme of today's talk, which we are talking in the next 40 minutes to you all. Why simulation matters now more than ever? Because emergency medicine is evolving, it's more complexity, and it's a high acuity, high pressure environment, and if we do mistake, the situation or the situation is not coming for you. Means we have to deliver best in high pressure, but for that simulation plays a big role to sharpen our skills. So aviation, I think we should learn. Aviation has evolved before emergency medicine or medicine, and they do some four things like rehearse real catastrophe, train the teams and not individual. Of course, emergency medicine is like football. We have to perform like a team, and if we perform like a team, then we will achieve the goal. Debrief every event, any good resuscitation or bad outcome, we have to debrief and we have to learn, and we have to learn from near misses. So these four pillars are very important that we should be adopting from the aviation industry. So this science of simulation has clearly showed that there is visible improvement in procedural accuracy, reduction in critical intervention time, there is improvement in protocol compliance, and there is reduction in adverse events in simulation. And it also helps in managing the crisis resource management. So what experiment with of simulation we have done? For ICD, we have been training our trainees through this goat chest. Thus we use goat chest for ICD insertion, and it gives real feel. So we sometimes these people do on intubation on a goat chest, and then immediately after that we allow them to do on a real patient, and due to the real feel of the interpostal space, they do very well. I think this has helped us to impart skill of ICD insertion among the trainees. So basically, world-class simulation does not require world-class budget. Simulation is not a device; it's a mindset. So we have to do certain innovation, and I think that particular innovation helped us to master on that particular resuscitative procedure. Now, intra-osseous, again, this is very important. In pediatric, we have to take the intra-osseous line, but it's less practice. In adult also, if you are not getting line, one is not getting line, we have to do the intra-osseous line. How we practice? So we practice on the model, but we practice on real bones. Now you ask me where we got that bone. We have borrowed from our first year students, and we bought them some bones, and on bones we gave them practice, and immediately after that, after giving that particular practice, when in real time, our trainees now able to do intra-osseous lining in patient within 60 seconds. So the real feel is very important. Means rather than high fidelity, as closer we go to the realness, then the real tissue feel that will work more. Central line, another, it's I think we do daily in emergency department, and it's very carry significant risk when we do without training. So what we do the central line training. Now here is an ultrasound guided central line. This is how we train our trainees in ultrasonography guided central venous catheterization, and in phantom limb, just to position the needle, how to approach these things, we practice on that phantom limb. So ultrasound guided vascular access, dynamic needle visualization, guide wire handling, under sterile technique, and complication prevention. All these four things we can achieve these things. Competence before patient contact, it is not guidance, it is our obligation. So everyone has to practice before touching to the patient in central venous catheterization, and that practice can be done in mannequins. Airway, I will not talk much about. Jack has taken very good lecture on these things, so I will not talk. But for my trainees, this is one thumb rule. They have to intubate 100 times on the mannequin before attempting for the patient. Means it takes 3 hours to intubate on mannequin for 100 times. They get drenched with sweat, but when they do after that on a patient, they will intubate very easily because that will give hand-eye coordination and that will build muscle memory also. So these simulations help in these things. So now we have integrated our mannequin with this AI. So it gives real-time feedback to the person who is intubating. And yes, rapid sequence intubation, difficult airway management, video laryngoscopy, and failed airway and cricothyrotomy. That things we train here. Now the focus has changed entire ball game. Point of care ultrasound is a new stethoscope, and any patient presenting to emergency department with undifferentiated breathing difficulty or undifferentiated shock, the focus is game changer. So we have to train people on the point of care ultrasound. Then what we do, we train them on the patient and then we take the competition among them. I think this point of care ultrasound different skill we teach to them and we take a competition among the students. This competition happened at Bharti Hospital, Dr. Shweta is here. So among the trainees we give the time bound competition to diagnose the condition. What things which cover means they should be able to diagnose tamponade. They should be like able to diagnose RA airway dilatation. They should be able to diagnose pulmonary edema. They should be able to diagnose collapsed IVC and hyperdynamic heart. So these different scenarios we give and on that they get trained. Again, dysrhythmia, again this is I think this is a practice widely. We have a simulator for this. What it helps, it develops the cognitive speed. And that is not speed, that is not a talent that one has to acquire through the practice. So in different kind of scenario we give to them and on that thing, different type of, suppose pulseless ventricular tachycardia, they have to start chest compression then defibrillate. Ventricular tachycardia with pulse, then they have to check blood pressure and based upon hemodynamic stability they have to do. So different scenario we do them and we train them on ventricular fibrillation, pulseless ventricular activity, toss-a-pontic, complete heart block, and on these things they get trained. And cognitive speed under pressure is a trainable skill. We have to train that thing. Repetition, variation and feedbacks are very important. Now this is interesting concept, like we saw the focus war today in the morning, so we do a sim war. One of my friend Dr. Nitin, he's my colleague, he conducts every year this particular program at Apollo Hospital. Means all across the people from Maharashtra and in Indian region they come, the teams come and we have a competition among the students there. And they perform, 100 people are sitting in front of them and they are performing there. So what will happen is they will have, it will give a mindset of performance under pressure. Suppose 100 people are observing what you are doing. They have one, they will perform under pressure. They will learn communication, prioritization, decision making, and simulation awareness. So competition introduces a control stress, and in control stress they practice. And one thing we have to always understand that excellence is rehearsed. Champions train in conditions that replicate in arena. When we train in a simulation lab, we can replicate in the resuscitation room. And this is another, these things, perimortem cesarean section. This is another rare condition. So rare condition we can't practice on a patient. So we have to train on them. Another, this beautiful workshop we conducted at Pune Bharti Hospital, where we have trained people how to do the perimortem cesarean section. So I'll just give you a glimpse. So this practice we have to learn. This peripartum cesarean we can't learn on the patient. We have to learn. But when it comes, and if you are able to deliver, it will differentiate between outstanding emergency physician and medical emergency physician. You have to train these things. And of course, after this workshop, when their team went for in the situation maternal cardiac arrest, and they did well and they survived. They saved both mother as well as child. So these things help. If we train, and then we get opportunity, we can give result. So what is the maternal cardiac arrest, team activation, and we have to take a decision in 4 minutes. If 4 minutes patient patient not revived, then we have to do the cesarean section. Some condition do not wait for experience. Simulation is the only way, ethical way to learn this skill, and when it is required, we have to go and perform there. Because that, as per guidelines, if arrested, even if obstetrician is not there, you have to go ahead and do the take the knife in your hand to save the mother. This is another resuscitative thoracotomy is another very important that, and in stab injury it's very often, and that we can't go and learn on the patient. So we have to learn on these things. High fidelity mannequin, they are not available everywhere. So what we did for these things? What we did a cadaveric. This we practice on cadaver. This regularly practice on cadaver. This particular clamshell thoracotomy me and my colleague Vivek has done. I think within 3 minutes we have opened these things. You can see.
Clamshell thoracotomy. Here you can see the diaphragm, here the lung, and here you can see pericardium. And then the pericardium, when we go inside and do the cardiac massage.
So what we learn is how to take the thoracic. This left side we have to enter, then how to when to do the clamshell, and then how to do the internal cardiac massage, when to do the aortic clamping, and team coordination. These are high stakes. Means if stab injury patients come to your emergency department and you get arrest, we have to do the resuscitative thoracotomy. And that skill we have to learn, and that we can learn over these things. And when we practice on cadaver, in real time, when you do in ER, the view will like this thing. You can do immediately and you can save the patient. So eCPR, I think eCPR is one of the skill which the simulation helped us a lot to learn learn here. We practice patient selection, how to activate the team with ongoing high quality CPR. We have to do the cannulation under ultrasound guidance, and then ECMO initiation. All these things we have to practice. And for this practice, we regularly, monthly, we will learn the such a thing. Basically, with these things we have to practice. In patient time, when we practice it several times, when patient comes, then we will deliver. And here we we see what mindset we get: leadership, communication, human factors, and teamwork. eCPR is not a procedure; it is elite team performance. I don't call it as a team performance; it's elite team performance, because we have to actually work like a team to save that patient. And if we do several times. And then I can think we did several drills on this thing, and I'll show you. This is our first eCPR patient, 19-year-old female, severe tuberculous myocarditis. She got arrested, and on that we did an eCPR, and this is her situation on day 10. And this is our first eCPR survival, so that's why I'm telling you it's 19-year-old.
Good. Legs karo, kick karo. ये वाला left. Good. सामने देखो आप.
So basically, credit will give to that the simulation practice which we have done on the mannequins for this patient. So always the program establishment, then initial simulation thing, then performance measurement, and of course there will be continuous improvement will be there, and then program gets mature. So after each eCPR, you will get more experience, you will learn more things, and it's doable in emergency department. I think we have been doing the eCPR in emergency department since last 3 years, and I can say we have very good outcomes in young patients. So simulation, performance, and survival. These things in this way it should go. And I'll tell you another last video I would like to say with that, because when we do the practice of resuscitation, and then we can excel in these things. This particular case, I would like to share that this 32-year-old was brought to in AS-Systole to emergency department. We started CPR, and after 2 minutes, that 10-second window we saw the patient is in tamponade. Then we did the on-the-spot pericardocentesis there, and this patient immediately heart got restarted with sinus rhythm. So I'll show this video. I think this video defines talks more than.
वेरी गुड. ये चालू रखना है.
नहीं ये अभी रिसेसिशन मत करिए. ये खोल.
हाँ ये वाला भी चलेगा.
डाल. वेरी गुड. सही हो गया. ये डाल दो. डायलेक्ट करके वो डायरेक्ट जाएगा. डायलेक्ट करके
अभी ड्रॉप लगा रही.
जाओ मुझे. हाँ ये टॉप सेटअप कर दे. रिदम आया.
अरे 5 centimeters.
वेरी गुड.
Yeah, immediately rhythm came. As soon as we drank 50 ml, we got a rhythm.
आगे हम लोग
आगे, आगे।
बस एक पास दे
तर हे टाकून द्या
It was A6 because heart was not able to move into the temporal.
नहीं इनको दे मेरे को ये 20 cc सिरिंज और ओपन कर ओपन कर ओपन कर ओपन कर बस बंद कर
तो डायरेक्टली सिरिंज लगा के है ना
लॉक दे हां तारा
कनेक्शन के लिए बॉटम में मिलता है.
अरे कल्चर में बेटा
So you can see the temporal part of the doctor from there. Under guidance only we get. So basically, the role of simulation, our ultimate goal is a patient survival. No education, no simulation education. Simulation education is not our goal. Simulation certification is not our goal. Simulation itself is not our goal. Our goal is patient survival. So I think who are we masters of? We are emergency medicine. Who are we masters of? We are masters of resuscitation. We are masters of resuscitation. When situation is uncontrolled, we raise. With that concept only, we are hosting our 20th National Conference of Society for Emergency Medicine in India on Mumbai on 30th, 31st October. And the theme of that conference is Excellence in Emergency Medicine begins with excellence in resuscitation. I would like to host you all to Mumbai for this wonderful conference. Thank you very much.